Welcome, everyone. We're so glad that you could join us today for the Underserved Population Network Coordinating Call. I'm Misty Kavich with the HHQI team. Also joining us today is Andrea Lefke and Misty Dyke. Today's session is entitled Best Practices for Care Transitions, Engaging Emergency Departments and Urgent Care Centers. As we continue as home health agencies or really in any setting for any of those that are on this call today or listening to the recording, we are working on reducing readmissions to inpatient facilities such as hospitals and skilled nursing facilities. As we look forward, how can we collaborate with others to really break that cycle of readmissions? Two specific areas that will be discussed today is working with emergent care and urgent care centers. Because if we can create really good care transitions to and from these settings, we'll be able to create opportunities to keep the patient at home where they really want to be, improve outcomes, and reduce costs. So today, I'm very pleased to have Dr. Rebecca Gardner as our featured speaker. Dr. Gardner is the Senior Medical Scientist at Health-Centric Advisors, the Rhode Island Quality Improvement Organization, or QIO. She is also an Assistant Professor of Medicine at the Albert School of Medicine at Brown University and a practicing internist at Rhode Island Hospital. So she has multiple roles that enable her to combine both clinical expertise with the implementation and evaluation of healthcare quality improvement interventions and policy. So with that, I am very excited and ready to turn the presentation over to Rebecca, please.
Thank you for that very nice introduction. If I could have control of the slides. Great. So I'm delighted to be here speaking with you today about care transitions. It's really one of my favorite topics, and it's fun to be able to present in the company of fellow enthusiasts like yourself. As Misty mentioned, I am a physician and internist. In addition to working at the QIO, I teach residents and medical students and see patients, both in and out of the hospital. Our patients are primarily underserved. About a third are uninsured completely, and the rest are a mix of Medicare and Medicaid with a substantial portion of dually eligible individuals. Let's get started. When we talk about care transitions, we traditionally talk about the hospital and how the patient makes the transition out of the hospital to home, and where they might be receiving home health, or maybe when they go to the hospital to a skilled nursing facility. All the settings you see here on this slide. But there are a couple key healthcare settings that are missing from this standard framework: the emergency department and urgent care centers. And I hope that by the end of this talk, I will have made the case that these settings are critical to include in any care transitions quality improvement efforts. And this is particularly important for home health clinicians because you are often the ones considering whether the patient does need to go in for additional evaluation and management. Here's what you can expect over the next half hour or so. First, I'll touch on what a QIO is, and I know that many of you either work for a QIO or work with QIO, so I'll keep that section brief. I'll then describe the opportunity that exists in the emergency department and urgent care settings. These are really areas that have not been widely brought into care transitions activities to date. Next, I'll talk about the safe transitions best practices for the ED and urgent care, and I'll describe some other approaches that other folks are trying. And I'll end by laying out a path for moving forward in these settings. A QIO, as many of you know, is an organization that contracts with Medicare, and by law, the mission of the QIO program is to improve the effectiveness, economy, and quality of services delivered to Medicare beneficiaries. QIOs are private organizations, mostly not-for-profit, and are staffed by healthcare professionals like yourselves, nurses, doctors, and others. We contract with CMS to implement whatever Medicare's priorities are for patient safety and for healthcare quality. And we work within a wide range of settings, including home health, of course. So one of Medicare's quality priorities back in 2008 was to begin the work of improving care transitions. And CMS started off in this area by doing a pilot. And Rhode Island applied for and received one of the 14 contracts that were given out across the country to do the pilot work. Each of the 14 communities was a petri dish, essentially, to see how evidence-based interventions actually worked in the real world. For the 3 years of this initial contract from 2008 to 2011, we worked really hard to bring providers from all settings together across Rhode Island in an effort to determine what were the root causes of poor transition in our communities. We also wanted to establish expectations for our providers and for our patients. We assembled a leadership advisory board and defined a broader vision for success in our state. And this is where we wanted to go. We wanted a healthcare system where patients and their caregivers understand their conditions and medications, know who to contact with questions and when, and are supported by healthcare professionals who have access to the right information at the right time. We started the hard work of getting there during our pilot program. And we built on that foundation when Medicare decided to expand the pilot program to all 50 states in 2011. So the work in our current contract, which runs from 2011 to 2014, covers 4 major interventions, which you see listed here. And I could talk about each of these for the next 20 minutes or so, but I'm instead going to focus our discussion on the area of safe transitions best practices, specifically those for the ED and the urgent care settings. Why the emergency department? We didn't start out there. We started out where everyone else does, in the hospital. But in developing our best practices for discharges from that setting, we quickly learned that involving the ED was really critical. First of all, a ton of patients are seen in the ED, 130 million a year. And of those 130 million, 82% are discharged out of the ED. They're not admitted. Of those 130 million, 63% have a discharge plan that specifies some sort of outpatient follow-up. These are sick patients, and many have a need for prompt follow-up with another physician after discharge. The doctors who are seeing these patients have to immediately assume responsibility for the patient's care, but they often don't have the information they need to do this. And at the same time, the home health provider who will be visiting the patient the next day as scheduled may not ever have even been aware that the patient had been seen in the ED. And the default, if the information that providers need is not there, is often to refer patients back to the ED, and often those patients get admitted again. This diagram shows how patients and their information flow in and out of the emergency department. Many patients self-refer, as you can see in the upper left-hand corner. Some are sent in from a nursing home or told to go in by a PCP or home health nurse. And of course, some are sent in by urgent care centers. We'll talk more about them in a little bit. When patients leave the ED, if they are discharged, information from that visit should follow them back to their providers in the community. But does it happen that way? Well, it turns out that it doesn't happen all that often. In a 2012 study, investigators found that less than a quarter of the time, PCPs were consistently notified when one of their patients was in the ED. The information that is transmitted to PCPs and others is quite variable. Unlike the medical literature that explores patient handoffs at change of shift in the ED, the available research in this, about this kind of communication is actually very limited. And in fact, there seem to be no data whatsoever on communication with home health providers. There are some guidelines about content for ED discharge paperwork, but little else in the way of national guidelines around the time of discharge. And I'm including a photo of the ED at my hospital where I work to say this is the state of the state here too. Well, perhaps patients could fill that gap. There has been some great research in this area, but the findings are a little depressing and probably not at all surprising to those who work in home health. In one analysis where they audio taped discharge instructions in the ED, the time allotted to this task was very brief, as little as 2 minutes in many cases. There was rarely any attempt to see if the patient understood their discharge instructions, and very important details were missing. So for example, most patients were instructed to follow up with their primary care physician, but 60% were not provided with a specific time frame in which they should do that, and only half the patients received some sort of explanation about what the expected course of their illness was. Even fewer were told what symptoms should prompt them to return to the ED or call someone for help. Many studies have shown that patients sent home from the ED don't really recall what their final diagnosis was or what the recommended follow-up was for that particular condition. And patients often do not follow up with recommended appointments. Not surprisingly, there's generally poor adherence to medications prescribed at the ED visit. As home health nurses, you work with these patients every day, so you see and you know these gaps firsthand. One solution is to identify standard communication processes and then define them so we can measure them. And this will allow primary care physicians, home health providers, and others who take care of these patients to close the loop. This is what we did in Rhode Island, and we call them the Safe Transitions Best Practices. What these best practices do is set out expectations for communication between providers. There's an element of patient activation here because we know that patients and their families need to own a piece of this as well to be successful. And the best practices were developed individually for each setting, and they focus on actions that are within the control of that particular setting. I know that all of you are also working within the framework of the BPIPs, and these do align with the 3 cross-setting BPIPs. Best practices have been created to date for 6 different healthcare settings, including the ED and urgent care, as well as home health agencies, primary care physician offices, nursing homes, and the hospital setting. The common themes across all of these are information transfer, both to providers downstream and to patients themselves, as well as their families. They also focus on patient activation, med reconciliation, timely follow-up, and providers responding promptly to clinical questions that come from other providers during the course of a patient's care. To develop the best practices for each setting, we took a multi-step process. First, we reviewed the evidence base for that setting and related settings. This was medical literature where it existed, consensus statements, national campaigns just like this one, and the guidelines of professional organizations. For step 2, we gathered statewide preferences and expectations from our community for communication to and from a particular setting. We used existing work groups and meetings, and then, based on those preferences and the evidence base, we developed our first draft set of best practices for that setting. We then convened a series of community meetings with the setting-specific stakeholders. We wanted to get feedback on the draft concepts, whether they seemed feasible, if the definitions and the metrics made sense, and we also wanted to ensure that these were usable within the setting workflow. We wanted to obtain consensus among the providers who work in that setting that these were the right direction to go in. And we also reviewed the specifications with health plan auditors to make sure that they were measurable from that perspective as well. Lastly, we vetted these best practices with our Leadership Advisory Board, and this board comprises a diverse array of healthcare stakeholders, nurses, physicians, pharmacists, and representations from commercial health plans, Medicaid, people from home health, hospice, the hospital, and nursing home settings as well. And here's what that process produced. I'm showing here the ED best practices just as an example. EDs should ask patients who their PCP is and if they're currently receiving home health. When the patient's discharged home from the ED, summary clinical information should be transferred promptly both to the PCP and to the home health agency. If the patient's sent back to the nursing home instead of maybe it's not a community dwelling person, then similar information should be sent to the nursing home. Med rec should be performed, although it's likely to be somewhat modified in the ED compared to what a PCP would do, and certainly compared to what a home health nurse would do in the patient's home. And then effective education should be provided to patients and their families, and this includes use of techniques like teach-back, where you do an assessment of the patient's understanding. It also incorporates elements of health literacy and is in the patient's preferred language. And lastly, written discharge instructions should be given. Now, some people look at these and think, well, gosh, aren't they kind of doing most of the stuff already? Isn't this kind of already required? And patients certainly think this is true, but as we all know, this just doesn't happen, and it becomes especially apparent if you try to measure it, or if you ask the downstream providers who should be receiving the information but aren't. Now, some ED doctors would look at this list and say, okay, this is fine. I believe this is all the right stuff to do, but how come when I'm trying to do the med rec and I call the PCP for a current med list, they never call me back? It's important to remember that each set of best practices focuses on action within the control of a specific setting, in this case the emergency department. The best practices taken as a whole are reciprocal, and they aim to provide clinicians with the information they need both from their upstream and their downstream partners. So back to that ED doc who wanted a current med list. For the PCP setting best practices, there is a measure there that outlines an expectation that a PCP office respond within 1 hour to phone calls coming from the ED or other acute setting about one of their patients. This is a photo of a beautiful New England old stone wall, which can last for hundreds of years, and we felt this accurately represented the persistent barriers to implementing these sorts of best practices in the ED. We all understand the time and workflow concerns, and this is generally what we hear first. Most ED docs know that these best practices are the right things to do, but EDs as a whole currently have very little incentive to participate in efforts like this. All of us, no matter what setting we work in, have other competing tasks that have to get done during the patient encounter. In the ED, they have to do things like HIV screening, domestic violence screening, assessment of suicide risk, and it's really difficult to add on what's seen as yet another thing. And importantly, standard ED metrics, what they themselves are measured on, are often not aligned with the work it takes to create a good transition for a patient out of the ED. Nurses and physicians are measured on things like total ED throughput time, the time from a discharge order to an empty room, and the number of patients seen per shift. So you can see how a focus on getting the patient out as quickly as possible might directly conflict with doing the right thing for a patient's discharge. But all hope is not lost. EDs are part of healthcare systems, and healthcare systems can set priorities, such as improving care transitions. And this sort of focus can push EDs to incorporate the best practices. We all know about emerging payment models. We've heard a lot about those, and these feature shared risks. And EDs can be brought into these agreements, which can also help move the discharge transitions higher up the priority list. Even without a new payment model, health plans themselves individually can write these best practices into their contracting requirements. And we've had approach with this setting in particular. We've had success with this approach in particular in other settings, such as the hospital and the nursing home, where the best practices have been written into contracting requirements by individual payers. And lastly, many people see patient satisfaction as an important quality measure, and readiness and preparation for discharge is one area where many EDs can improve a lot, and they can expect to see an increase in their satisfaction scores. Something else that seems to help remove barriers is publication of these concepts, particularly in an ED journal. And our team at HealthCentrics was fortunate enough to be able to do just that. This can help to disseminate the best practices, helps validate them, and being able to show a physician a publication can go a long way to securing buy-in. So we're going to shift focus at this point to urgent care centers. Urgent care centers are sometimes seen as the red-headed stepchildren of emergency departments, but this is not a fair assessment, and they really require a close look all on their own. They are a huge and growing business with 300 new centers each year in the U.S., about 9,000 total across the country right now. Patients are increasingly seeking care here, and this type of utilization can fragment care for a patient if he or she already has a PCP. Interestingly, half of urgent care visits occur during regular PCP office hours. And many urgent cares, when a patient does have a PCP, even when that PCP is known, they don't communicate at all with PCPs. Similar to EDs, we have no data available on whether or not there's communication from the urgent care center to home health agencies, but I suspect the answer is no. If information is sent to PCP offices, it's done pretty inconsistently, and there's a wide variation in what types of information are sent. Even more than with EDs, physicians and other stakeholders in Rhode Island specifically identified improving communication from this setting as a really important need, and one that we hadn't originally anticipated. This graph shows the types of communication that are wanted by the ED doc versus what is actually received when a patient is referred to the ED from urgent care. This is a study done in Rhode Island with a survey of ED providers across the state. So on the x-axis, you can see things like a telephone call, the reason why a patient was sent to the ED, a copy of the chart, and so forth. And on the y-axis, it's the percentage of doctors who thought the type of information would be helpful. That's on the red bar, and the frequency with which it was sent by the urgent care center on the blue bar. So you can see there's clearly a mismatch between what ED doctors feel they need on the red bar and what they actually get on the blue bar from the urgent care. This diagram depicts the flow of patients and information to and from an urgent care center. It's a little more straightforward than the patient flow for an ED. Many patients, both those with and without PCPs, refer themselves. Some are sent in by home health providers or their PCP after hours. And when patients leave urgent care, they're either sent to the ED or they're discharged home. If follow-up is needed, they may be told to follow up at the urgent care itself to sort of complete a particular problem, or they might be referred back to their PCP or just told to find a PCP to follow up. To create the urgent care center best practices, we went through the same multi-step consensus process that I described earlier for the ED. Similar to the ED, urgent care centers are directed to ask both about the patient's PCP and about home health, and then to send information about the urgent care visit to those providers. When patients are sent to the ED from the urgent care for more evaluation, they're instructed to send specific clinical information to the ED, including both the reason for the referral and the expectation for treatment. some ways, the urgent care center is environment is even more challenging than the ED. Oftentimes, we don't even know who the urgent care center physicians and who these centers are. The urgent care umbrella, that name, covers many different types of entities, many different types of names. There's no real central body, no board certification, professional society that acts as a representative of these organizations. And regulatory requirements vary by state, and the regulation is often based on what type of entity happens to own the urgent care center. Many different types of physicians work here, and there's a lot of turnover. They also, similar to EDs, do not have a lot of incentive to participate, perhaps even less than ED docs do. Unlike EDs, urgent care centers are often not part of a larger healthcare system that might be prioritizing patient care transitions. The ED at this point has a lot of medical journals, robust scholarship, but this is really not the case with urgent care centers, and this makes dissemination of standards even more difficult. But again, there's hope. Many PCP offices are participating in patient-centered medical home models or other comprehensive primary care initiatives. And already the Joint Commission stipulates that PCPs should provide 24/7 access. Urgent cares may have a role to play in this if they can provide that access if a PCP office is not otherwise equipped to do so. So they can be that 24/7 if a PCP is a small office and not able to provide that kind of care. Urgent care centers can then, if they're willing to do this, can enter into a partnership or a compact with PCPs. But with this would come a minimum level of communication back from the urgent care center. The urgent care center would get increased volume of paying patients, but the PCP should require that the urgent care center communicate back with them when one of their patients comes in. And it can be the types of information that are delineated in the best practices. Certainly, urgent care centers who do communicate well, and there are some, are noted by the ED and by PCPs, which strengthens the reputation and also generates referrals, even in a more informal kind of way than with a compact. As with the ED, payers can certainly act to include these best practices in their contracting requirements. And in states where there's not full penetration by urgent care centers, abiding by these best practices, for example, could be a condition of participation in that state. So for example, in Rhode Island, we do not have retail clinics like Minute Clinic and other facilities which are set up within you know, a Walmart or a CVS or a Walgreens. Those don't exist in the state. So if we included some sort of standard on expectation for communication, that could be part of the negotiation to allow organizations like that to take root in our state. Our team is fortunate to have an article on the urgent care best practices coming out in the July issue of the Journal of Quality and Patient Safety. We're excited about that. The safe transitions best practices I just described for the ED and for the urgent care, they're a key component to improving care transitions in these sort of more non-traditional settings. But there are other approaches that I did want to highlight. Kevin Bice is an ED physician who works for the Carolinas QIO. He's also doing work in the ED, and he and his colleagues at UNC are piloting a transitional care area in the ED for patients who have complex discharge issues. In other hospitals, these are folks that probably would just automatically get admitted, but his work hopes that by identifying these patients as high risk and allotting additional resources to them, that admissions and readmissions particularly can be avoided. Part of the intervention is communicating back with the patient's providers in the community. Some other ED-based efforts are highlighted on the AHRQ Healthcare Innovations Exchange website. Most of these are focused on underserved populations, such as those that you care for as well. And these include a variety of things. One of them is a ED-based care manager who can actually schedule new clinic appointments for patients who are discharged from the ED that don't have PCPs already. A number of the programs there feature coordinated intensive medical and behavioral health care services for high utilizers. And most of the high utilizer programs actually don't include home health agencies in their protocols, which seems to me a large oversight given the important role that these folks play in keeping these complex patients in their home. ED physicians will often say, and I'm sure you've heard it as well, that if they knew there was a home health nurse who could see the patient the next day to follow up on a specific concern and who could coordinate with the PCP, the ED doc would often be a lot more comfortable discharging that patient home instead of the inevitable admission. So we've been working on care transitions in these non-traditional settings and others since 2008, about 6 years. And I wanted to share a few of the things that we learned along the way. You can probably all relate to the first point here. It takes time to get things started. People really needed to express how frustrating it was to work in the current system before they could move on and tackle solutions. And for us, it took a while to get there. I would say for most of our settings, it took about 6 months. There are many other efforts going on in the local environment, as you know, since you're involved in the campaign. And we found that it was critical not to duplicate what other folks were doing. That was very confusing for patients and providers alike. We found that data was one of the most critical, continues to be some of the most critical pieces for us. Being able to measure and track change over time, it's fundamental to improving care transitions, doing any QI work in all our settings. And ultimately, it was the most convincing argument about why things needed to change. We also found that we needed to examine broader outcomes, not just readmissions, but all unplanned care. So we included things like ED visits and observation stays. We also looked at non-traditional measures like how our PCPs, what their assessment of communication coming from the ED and hospitals was. And this, we seem to need this in order to really get a sense of the full picture of how things were going in our community. And lastly, we included the payers at the outset, and that's been very helpful for motivating our partners and for achieving sustainability. As I alluded to earlier, publishing and presenting efforts at national scientific conferences goes a really long way to disseminating what you're doing, and also helps build credibility with providers who may otherwise be reluctant, and our QIO has worked really hard to do this. So before I wrap up, a brief comment on what all of us are doing. Medicare originally termed this body of work a readmissions reduction program, but this is really not what we're after. As evidenced by the upcoming scope of work, Medicare is definitely starting to recognize that safe transitions is not just about reducing readmissions. We, you, us, everyone, we're trying to make care transitions as safe as possible for our patients in every care setting and with all our providers. So I think it should really be more of a, wait, you were in the hospital reduction program? We're trying to reduce the chance of any PCP or any home health nurse ever having to say that again. I think Eric Coleman said it best when he noted that the greatest opportunities for improving care transitions center around communication, cross-setting relationships, and workflow redesign. And this is certainly true in the ED and urgent care settings. Any work of this magnitude is a team effort, and we have a great team. I really hope that you'll contact me or Lynn Chase, our Stellar Program Administrator, if you have questions, if you wanted to collaborate, or you wanted to share the work that you're doing in the ED, urgent care, or elsewhere. And I really appreciate the opportunity to talk about our work. Thank you.
Thank you so much, Dr. Gardner. I will put a plug in right away if you have questions, and we do have a couple already in the hopper. So if you have questions for Dr. Gardner, please go ahead and type those into the Q&A or provide those into the chat, and we will collect those and ask those. And we have plenty of time, so I know this is a very hot topic, and taking the information and sifting through it. So come up with some questions. I'm going to start with the first one, Dr. Gardner. Now, I don't know if you'll be able to, I know you're from Rhode Island, so you may not be able to answer this, but this is from one of our participants. Do you know if New Jersey requires PCP access for 24/7? I know it's a different state, but are you aware of that?
That's a great question. That's actually a Joint Commission standard. If a PCP office wants to be accredited by the Joint Commission, one of the requirements that it has to have 24/7 access for its patients. So that's not a state-by-state thing. That's if a practice wanted to be accredited by the Joint Commission.
Very good. And a lot of hospitals are or do follow the standards for medical practices as well. Great. We have another question from David. Are EDs now dedicating workers and appointing tasks to follow up with patients after discharge? And are EDs getting compensated for documenting follow-up?
I love that question. That's a good one. So I think it sounds like a two-parter. I can probably
It
answer the
is.
second one first. Okay, the second one's probably easier to answer, which is that no, they're not, unless that the hospital system they themselves work for is incentivizing that particular task. So different health systems have different sort of pay performance within their own health system. So unless they've targeted that as something they're following and tracking, probably not getting compensated. The other caveat would be if one of their insurers they're working with has a particular interest in this, sometimes they'll put in specific quality incentives in their contracting that will allow payment for those, but it probably isn't going directly to the physician or staff member themselves, if I had to guess. Regarding the first question, which I think is a little tougher in terms of who's actually doing this work, if that's an accurate paraphrase. So oftentimes when a PCP is called, that's a physician-to-physician practice. In RED and others, they're using the case managers to reach out to the home health folks. Sometimes the clerk will put out the initial call and then bring the doctor on when the other person's on the line. I don't think that necessarily works as smoothly as when the physician reaches out, but it certainly is a time saver on the ED physician side. But there are a variety of different solutions based on the size and acuity of your ED and also one's relationship with the surrounding primary care community. So small ED, well-known PCPs around the area, only a few home health agencies, that's going to be a much different scenario than a large academic urban teaching hospital, for example.
Great. Thank you very much. We have another question. When working collaboratively with EDs, who have you found that sit on your committees? Either the nursing managers, staff, physicians, and that was the type of the question.
When we've had our stakeholder committees and so forth, we had targeted a couple of different people. Often EDs, especially in the larger health systems, will have a quality director that's often a physician or a nurse or both. And so those are great people to bring in because this is already part of the mission of their work. Certainly the medical director is often too busy. You might have to go with the assistant or associate medical director, a charge nurse or someone who can speak to the the nurse workload and workflow, very helpful as well. And we also just had physicians in the ED who are just personally interested in this.
Great. And we have a question from Jennifer. From your research, was there a best practices for home health care clinicians and agencies generated? And I do know you talked a little bit about that. There's the second part of that, but we'll stop with the first part. Was there a best practice?
Yes, absolutely. So we did develop best practices for 6 healthcare settings, and home health agencies was definitely one of those. That was done with the same process. So looking in the literature, and I have to say, compared to hospitals, there's just much less, randomized controlled trial data for home health, for the home health setting. Most of the work that there's data for is outside folks coming into the home that were started during the hospital discharge process. So, for example, Eric Coleman's model of coaching, where someone goes into the home, often that's not your routine visiting nurse service. That's someone who's kind of put in specifically for that project. So in terms of randomized controlled trial data using home health agencies, a lot less out there looking specifically at readmissions in a randomized way. However, we did take the few stuff that was out there. We looked to a lot of national guidelines and campaigns, and then we after we drafted an initial set, we met with home health nurses and administrators in the agencies to vet these best practices, and we can certainly make those available to you. I think the slide with the email addresses is up there, and certainly that Misty has our contact information. We'd be delighted to share those with anybody who wanted to take a look at those. The home health measures not only have the best practice themselves, but they have definitions, numerator, denominator, exclusion criteria, all the standard measurement tools that you would need to actually implement them in your particular setting. And these are not best practices for how to be a great home health nurse. These are best practices specifically for care transitions.
Great. And I think the rest of her question, she mentioned that she did see the ED urgent care. You mentioned that there were 6 settings. What were they that you worked with?
ED, urgent care, home health, nursing home, hospital, and PCP office.
Great. Great. Okay, our next question, great questions coming in, so please continue to send those into the chat or to the Q&A windows. The next one comes from Lynn. How does the ED identify the home health agency if the patient is a poor historian?
This is another great question. I think asking the patient who their home health provider is really tough. Oftentimes they'll even struggle to identify who their PCP is, so expecting them to remember the name of a home health agency is very difficult. That's often where a case manager, social worker, clerk, someone else can help the physician to call the patient's home, have them look on the fridge, where often the home health nurse will have a magnet, go through the card. If the PCP office is open, they'll often have a record since they'll be signing off on the orders, or they'll often refer to one home health agency in particular. But I would agree that can be a tough thing to find out. Another thing you can do, which takes more time, is go into if they're back in their usual hospital, if you can pull up the last discharge paperwork, you can see what home health agency they were discharged on. So there are a couple of tricks that one could do to find that data, but that is having the patient identify who the name of their home health agency is sometimes really tricky.
Great. Okay, I have, make sure I got the right. I have a question from Anna Lynn. I heard that the speaker talk about the ED case manager making PCP appointments. Are your ED case managers 24/7? If not, what hours do they work? And how many appointments may truly occur? And she does have another question, but we'll stop there.
Okay, thanks for that. The study I was referring to was not one that our QIO or EDs was currently engaged in. Those were examples of innovation projects that are funded by AHRQ and are on the AHRQ Innovations website. That was to give an example of the broad array of other innovative projects that other states and hospital systems are doing. So in that particular innovation project, which was not in Rhode Island, their case managers, by some act of God, I don't know, had access to PCP office, scheduling databases, which is amazing, and we're able to make new patient appointments for patients. So that's amazing. We don't have that in Rhode Island, and most people probably don't have that where they sit either. Our case managers at our hospital who don't make patient appointments at all ever are generally here sort of an extended, 7 to 10 sort of schedule, and that's not every day. They're not 24/7, and they never make appointments.
Okay, and then the additional piece of that was, and did you see an increase in keeping PCP appointments and a decrease of unnecessary ED visits?
So we haven't focused on making appointments for the patients coming out of the ED, so I can't answer that question, but that would be a very appropriate outcome measure if someone were to undertake a study like that.
Great. Well, we are getting a variety of questions from a variety of participants that would like to know if you were able to share your best practices. It's interesting, we have BJ that's on our call today, that they're going live with a transitional care program in California in July, and they're going to be referring as needed to home health, et cetera, and any other community referrals, PCPs, et cetera. And she would love to see your processes as well as several others. So is that something that you have posted on your QIO link, or is there something that you would be able to make available for our participants?
Absolutely. We have it posted currently on the Health Centric Advisors website. It's healthcentricadvisors.org, and there's a big button on the website that shows you where to go for more information about care transitions, and then we have each set of the 6 best practices posted there. We would certainly be delighted to provide any assistance, answer questions, and chat more about those with any individuals who might have additional questions after looking at that, or who are not able to find them, and certainly by contacting us directly or going through Misty, we'd be delighted to help you walk through those.
Great. We will go ahead and put a link out with a copy of the recording, most likely tomorrow afternoon, if not on Friday. So we will include that link for those packages. And there are many people on the call today. We had such great response that work in other settings and may be very interested in looking at those as well. Let me see. Here's one from Lynn. Our home care agencies trialing an armband identifier.
That's an interesting question. We have heard of that, and we actually have some PCP offices who would like to trial an armband or some special way of identifying that the patient is a patient of that particular practice when they go in. And so, when a patient visits ED, for example, their armband will be blue instead of white. I'm giving that as an example to alert the ED physician that this is a patient for a particular practice. My guess is that the caller was specifically asking about putting a standard bracelet on the patient kind of at all times, so that if they were to present for care, unplanned care, that or even at the PCP office, I suppose, that someone would know that they were a patient of a particular home health agency and they could reach out specifically. I have heard of that being trialed. I don't believe that's going on with any of our communities in Rhode Island, but it's an innovative practice, and I'd be interested to hear about the results both from the patient acceptance side and then from whether or not that results in improvement in communication.
Oh, that's very interesting. Thank you. Let's see. I'm also trying to look up the link that I could post into the site here for you in a minute. Let's see. If there are any additional questions coming in, please go ahead and put those in to either the chat or the Q&A. Right now, I think we have covered all of the outstanding Q&As. But I'll go ahead and let you continue for a few more minutes. I want to thank you very, very much, Dr. Gardner. I think the work that you have done with the QIO is outstanding and really takes a look at the next layer as we continue to work with our hospitals and creating these partnerships and collaborations. We're able to extend that into specific areas, and each community will have different needs, and each inpatient facility may specialize in different care that they provide as a disease management or a type of procedure or surgery that is done that they could really work individually. But reaching out, trying to break that cycle and working. I think it'll be very interesting. I think some of the barriers that you have brought up make it very difficult with the competing barriers, the time frames, the different outcomes. I know I just went through 2 emergency room experiences over the weekend with my mother. So, thinking, how would you stop from having a readmission, and we're leaving one facility and end up in another facility, and how could that have been proactive? But it is a very complex, but where we that work in home health can make that as a solution, but we can't be the barrier. We have to really figure out ways that we can communicate well. And I think a slide early in the presentation with the graph of what doctors want and what they get was very telling. Actually, if we turn to the next slide, well, we will continue to entertain some Q&As as they come in, but I'm going to go over a few resources that are available either through HHQI or some others. And these are just some simple resources but can be very instrumental in the work that you're doing. SBAR is a communication tool, is very significant. And so I think taking a look at what the ED physicians are asking for are things that could be very easily integrated into an SBAR form when you're either calling report, which it looks like they really prefer to have a verbal report, or a fax report is sometimes what we do see. But they want information that we can provide in a simple format that's very concise. There is SBAR tools that are provided in the Disease Management Heart Failure BPIP, as well as using the CHAMP, Advancing Home Care Excellence. There are some tools, resources, PowerPoints. If you've never heard of SBAR or not currently using it, can give you some good information too for education. And we'll look at the next slide. And some additional resources is looking at how to create these collaborations. You really do need to reach out, but there are some tips and ideas that will help you with creating these smaller collaborations. If you're already working with a hospital setting, that's great. Most of the care transition setting projects that I have worked on, there typically is a ED representative on those committees. But getting started either from nothing or if you're in the midst of doing other collaborations, there's some simple tips in the underserved population BPIP. Med reconciliation is huge with trying to keep patients from that cycle, making sure that they follow up and are on the meds that are ordered from the ED as was mentioned earlier in the presentation. We have some really good medication reconciliation tools and resources and education for clinicians, as well as in care transitions and handoffs. As mentioned before, too, Cross Settings 2B PIP from Phase 2 really does include a lot of information about care transition. If you're not currently working with care transition, and there are several types of programs right now that are occurring either with the QIO program or also there's a CTT, there is also another program, a national program that is going on. A lot of times the AAA, your Area on Aging, are involved, collaboration between hospitals, community services. But care transitions can reduce and make a significant difference. The research has shown that over and over. It is a good way to create relationships in doing that. It was so nice. My mother is being discharged from the hospital as we speak today, and yesterday the coach came in to introduce herself and explain what care transition was and how we do healthcare coaching and using some of the tools and resources such as a patient health record. So, you know, it was great to see the theory truly being played out in action, even in a local hospital that I had not really participated in any work there. So on the next slide, we just have a little update, and we'll come back and look, see if there's some questions here in just a second. Our next Underserved Population Network event is also an excellent presentation, just like today's with Dr. Gardner. Great information, great insight. The call in 2 weeks is on Alzheimer's disease, or really any type of dementia, a new way of understanding for the home care worker. And Jane Marks is a consultant on dementia care, and she has a sandwich caring website, and she's going to talk about really understanding communication with patients, looking at how we deal with caregivers as well, because a lot of people are still working and trying to manage and care for their elderly family members. You can register at the website on our Up tab, and that will be on May 8th, 3 to 4 Eastern Time. The next slide, please. There's different ways to connect. We have a great information that we post on Facebook and Twitter if you look there, as well as LinkedIn. We put tools, short resources, some real simple information. We have a weekly blog that has been getting great response, and we have different topics. We have guest bloggers. If anybody that is on this call is interested in even blogging on our site, just contact us through our HHQI email, and we would be very happy to discuss that with you. We're always looking for guest bloggers on different subject matters. We have a discussion forums as well as live chats. And before we go to the next slide, let me go back and look in the Q&A to see what's come in. Oh, great, Misty Dyke. She's posted the HealthCentric's best practice measure link into the chat box. So if you didn't see that, please make sure you look for that. And there are some teaching books that are also provided. There's some additional websites that are in chat, so please do see that. And I think we have one more. Oh, here we go. We have another question from David. What goals are you expecting from EDs in the next 5 years?
Well, I have a lot of goals for EDs, but I'm going to keep it to care transitions, if that's okay. I'd like to see EDs really become as integrated and invested in improving care transitions as the hospitals are. I think the EDs are actually really innovative and exciting places to do QI work because they themselves are pretty nimble and much more easy to make changes in some ways than a bigger hospital system, which is much more spread out. It's usually one employer for the physicians, another employer maybe for the support staff, so it's a little bit more manageable. I think they could be an amazing area for innovation and for experimentation. So I would really like to see them become active partners, especially in local PDSA efforts or even national trials. So some of the work that's going on looking at transitions units I think is really interesting. I'd like to see a change in culture where reaching out to the PCP and to the home health nurse is just sort of an expected thing that people do as opposed to being viewed as an add-on. So a bit of a culture shift, which I think will need to happen kind of at a higher up level and then be disseminated mercilessly throughout residency programs. It also would certainly help if medical schools put more emphasis on this, which they are already doing, so that anyone entering into any residency program, ED or otherwise, would have this be acknowledged as an important part of being a physician. Because sometimes it is seen as an add-on and not just a normal part of doing the job. It's a really critical part. So I would say those are some important areas. You know, there is some research, but there's not a lot of research. So I'd like to see, in addition to local QI project, I'd really like to see folks engaged in maybe even a network of innovators doing research at multiple EDs that could have very generalizable and findings that could be disseminated widely. So I think there's a lot of potential there. There are some robust research programs already out there, but not really in this area. So those would be certainly places we could see more effort. You know, there's a new and expanding movement for geriatric sections in emergency departments, and there's actually sort of a geriatric emergency subspecialty emerging. This would be a great place to see some of these care transitions practices piloted. That's obviously a very high-risk population. Those are very motivated physicians and nurses who have a real commitment to an understanding of the geriatric population and would probably more than others get the importance of doing care transitions right. So that might be a place to particularly look. In terms of urgent cares, you know, they're in a very different place in terms of both scholarship and organization. So they have a long way to go even to get to the place where EDs are right now.
Well, thank you again very much, Dr. Gardner. The information was wonderful, and we thank you for your time for sharing that. We thank all of you for joining with today's Underserved Population Network event. Please do complete the evaluation when you're finished. There's a short evaluation. We appreciate your time, and we hope to see you or hear you in 2 weeks for our next Underserved Population call. Thank you very much.